Наступна доповідь Joachim Oertel, лікар з Хомбурга. Будь ласка, він онлайн має до нас доєднатися.
Thank you for inviting me to speak at the Ukraine International Symposium on minimally invasive spine surgery. It's a pleasure for me to be part of it for many years now. My name is Joachim Oertel. I'm head of the Department of Neurosurgery in University of Saarland, Homburg, Germany. And the topic of my talk is ISMISS Consensus on evidence for superior results with endoscopic lumbar disc surgery. These are my disclosures, which are unrelated to the presentation. This is where I'm from. I'm from Homburg, so not Hamburg, just Homburg, very close to the French border. It's about 1 hour drive from Frankfurt, Strasbourg, and Luxembourg. This is our university campus. And in the lower right, you see the Department of Neurosurgery. We perform about 3,500 procedures, including 400 endoscopic procedures and 400 MIS spine instrumentation. The department is well known for microdiscectomy, which was probably done in 1977, the first in the world. And Kaspar used to work here, so he did a lot of development of minimally invasive spine surgery. Is there any evidence for superior results with endoscopic spine surgery? We will focus on degenerative lumbar spine. Why? Because this is the most frequent indication. For this indication, most data are available. If it's the best indication for a minimally invasive approach, I don't know. This is what it looks like, what we talk about. You see a lateral approach, puncture of the disc, the in-out technique for transfemoral disc surgery, application of contrast dye, then using a curve wire, enlarging the approach, introducing the working cannula, X-ray control, then enlarging the frame a little bit with a drill, and going in with the endoscope. And here you see a typical ideal situation when the transfemoral approach was very successful just to the disc sequester and the sequel was taken out. So we talk about to compare this with a, maybe 2 minutes surgery to microscopic approach. This is also something we talk about. Spondylolisthesis, grade 1, very narrow spinal. And this is the procedure. You see the endoscopic tube-based application of the opening of the discs. The upper part is the medial, lower part is lateral, left is cranial, right is caudal. Enlarging the approach. When the cage probe is inserted, the cage selected, and filled with bone graft. All this is done under endoscopic view. Cage is further inserted and relieved. It's a T-lift cage, so we further push it to curve and be in the middle anterior position. What does it look like after endoscopic cage placement? We use the same skin incision for applying MIS screws, one side after the other. So this is an example for the first screw. Yamshidi needle, puncture of the transpedicular approach, insertion of the K-wire, and then application of the percutaneous screw. So all this can be done with a incision of 3 centimeters. You see here, this is the post-operative result. So this is what we talk about. Percutaneous puncture, this is the result on the right for the one-level T-lift. This compared with a standard microsurgical technique. Do we have evidence that this is superior? So theoretical advantages of the endoscopic approach are minimal muscular trauma, less damage to the bone and ligaments, decreased scarring at the dura because of mini-opening and higher magnification, reduced infection rate due to no contact to the skin, significant patient demand, superior cosmetic results, and less post-op pain. Surgical disadvantages are very different surgical technique for microsurgery, tight selection of surgical candidates required, and a prolonged learning curve. These are the typical current approaches. You see here various techniques from various different companies. I will not go into detail. Just in general, it's inter or intralaminar or transforaminal. What are the techniques? We have a tube-based endoscopic technique, we have the percutaneous full endoscopic technique, and then we have the biportal endoscopy. This is just a compilation of all the different techniques and their advantage. I will not go too much into detail. Of course, the larger the approach is, the more ability you have to adjust to the individual needs. And the more focused, limited your approach is. So like in the full endoscopic, you have a tighter selection of candidates and indication. There's a vivid controversial discussion in different meetings, sometimes very aggressive discussion, which technique should be valued over the other. So, but one of the consensus things was in our ISMISS consensus meeting is if you master any of the minimally invasive endoscopic techniques, you're convinced that these results are very superior to conventional open techniques. Then we went into evaluation of what is published about the three principles, so tube-based endoscopy, percutaneous endoscopy, biportal endoscopy. And it turns out that there's literally no evidence which values one technique over the other. So, is there any evidence for superior results with endoscopic spine surgery at all? We addressed these questions in 2 rounds of evaluations according to the Delphi method. So we went through the publications of the last 10 years, even older if they were landmark publications. Presented it to the faculty. We developed voting statements. The first round of presentation and voting was done online, only with the board of the ISMISS Society. And the second round of presentation and voting was done in September 24 during the ISMISS World Conference. And the subsequent publication is in preparation. And these are the first questions we asked: uniportal versus biportal, transfemoral versus interlaminar, pure endoscopy versus tube-based. And what do we know now? So, there are 343 papers available. They are in extremely diverging data due to different techniques and outcome criteria. We selected seven different topics. First round of online board members only, and 7 hours of presentation and voting. And second round during 24 ISMISS conference in September, all conference participants. So the second round was done with up to 134 votings. Just to give you an example, what was the presentation about? You see here a meta-analysis published in the Spine Journal in 21. Comparison of interventions for lumbar disc herniations, a systematic review with network meta-analysis. And you see that it's 32 studies with close to 5,000 participants. And this analysis, it showed that a single treatment could not be defined as the best. However, percutaneous discectomy and conservative treatment consistently perform worse than the other treatments. So remember, percutaneous discectomy and conservative worse than the other treatments. Next meta-analysis, published in World Neurosurgery 2018. Topic, operative approach for lumbar disc herniation, a systematic review and meta-analysis. 1,700 patients with open and microdiscectomy, tubular discectomy, percutaneous discectomy, and percutaneous endoscopic discectomy. Here are the results. Tubular discectomy was found to be associated with a worse ODI scores. In terms of complications, tubular discectomy was found to be associated with a greater rate of overall complications, greater incidence of dural tears, and recurrent herniation. So in this analysis, not the percutaneous endoscopic discectomy performed worse, the tubular discectomy performed worse. Another meta-analysis, International Journal of Surgery 2016. Comparison of percutaneous endoscopic lumbar discectomy versus open lumbar microdiscectomy for lumbar disc herniation, a meta-analysis. Here, 7 studies, 1,400 patients. The existing evidence indicates that no superiority exists between the two surgical approaches. In spite of no difference in terms of functional outcome, complication rate, and reoperation rate, the percutaneous endoscopic lumbar discectomy achieved shorter surgical time and shorter hospital stay. So another different result. Just 3 studies and just to show you what is the problem with the analysis, all demonstrated different results. So then we went to voting and tried to formulate questions where we can vote on. Both microsurgical and endoscopic treatment of lumbar disc herniation yield good clinical outcomes and are both viable operative options. Strongly agree. Fully agree. So 4. 100% of voters agree. Endoscopic surgery seems to yield to several advantages: shorter operative time, reduced intraoperative blood loss, lower infection rate, and less soft tissue trauma. All votings agreed. Median lumbar disc herniation, a particular subject. Endoscopic percutaneous transfemoral treatment of median located lumbar disc herniation showed excellent results, with low rates of recurrences as well as high levels of patient satisfaction. In the beginning, we said it was better than microsurgical interlaminar approach, but there was no consensus on giving this question. So with this question now, low rates of recurrences as well as high levels of patient satisfaction, all agreed. You see, 1/3 agreed, 1/3 fully agreed, 1/3 fully. But there's an extreme lack of literature concerning microsurgical treatment in cases of median lumbar disc herniation. Consequently, not much data on a comparison between the two treatments is available. So comparing to older microsurgical technique, endoscopic percutaneous techniques seem to yield to superior results in median disc prolapse. There was a fully agreement on this. So there were many, many more votings. However, we were a little bit surprised. There's no evidence that the complication rate is higher, is lower, particularly with wound infection. So what we could vote on, and where's evidence, is that the complication rate with endoscopic techniques is no longer higher than with microsurgery. And here you see we had 100% agreement. The smaller the worksheet, the smaller the muscular and the lost tissue trauma, there is evidence. 100% agreement. So, and we have with the endoscopic technique superior aesthetic results. This is an obvious evidence, but there are no studies available to show that. So at the end, we had to say that in the consensus meetings, there's no difference in long-term results. There's no difference in revision rates. There's no difference in long-term success rate. And there's no difference between microsurgery, microdiscectomy, and various endoscopic techniques in infection rate. Evidence that in the immediate postoperative period, the endoscopic techniques are superior to traditional techniques is there. We concluded that the same outcome with less muscular damage and superior cosmetic results we can achieve with endoscopic techniques. Indications in surgery techniques are continuously evolving, and endoscopy will play a significant role in the treatment of degenerative spine disease in the future. Do not miss the start now. And if you're interested, I'm happy to thank you for your attention and invite you to our endoscopy week, which will be from September 5 to 11, or to the International Federation of Neuroendoscopy meeting, which will be in Graz, Austria, the pre-Congress workshop 13 and 14 of September, and then the meeting in 15 to 17, and the ISMISS International meeting in October with Dr. Burkhardt, Professor Burkhardt in Zurich, Switzerland, October 3 to 4. Just mark it. And Professor Burkhardt is the president from 25 to 29. Thank you. If you're interested, just contact me by email. Have a nice further meeting.
Дякуємо доктору Joachimу Oertelю.